So there were these major landmark trials. I'll draw your attention to these two trials. That is the trial NEJ009. That was a Japanese trial. It was a phase 3 randomized trial. And this was a trial by Vanitha Norana and colleagues from Tata Memorial in Bombay. So these three large phase 3 trials, they combined gefitinib, which was the first generation EGFR TKI, as I alluded to in the previous slide. They combined this with chemotherapy. The common chemo drugs that we use to treat lung cancers are mentioned here. And there they conclusively showed that your disease control was far superior by several months by combining chemotherapy with these TKIs. So you can see that in the gefitinib arm, the median disease control was ranging from 8 to 12 months. But in the combination arm with the chemo and TKI, the disease control increased to 16 months in the TMH trial from Bombay and 20.9 months in the Japanese trial. So there was definitely some rationale to combine TKI with chemotherapy. So then researchers thought, let us combine chemotherapy with the third generation TKI and see whether that also further improves the outcomes. Because like I said, the previous trials were with the first generation TKI. So this was the most recent development in this disease treatment paradigm. This was the FLORA-2 trial. So this took patients of advanced stage EGFR mutant lung cancers. Of course, only adults were taken, and they were all patients who had the two common mutations, EGFR exon 19 deletion or L858R mutation as mentioned here. And they had to be newly diagnosed patients. Previously treated patients were excluded. Even patients who had brain metastasis. So brain metastasis is the, as you know, the most devastating complication of any cancer, because any disease which spreads to the brain causes a lot of discomfort to the patient and can profoundly impact negatively the patient's quality of life and the patient's lifespan. So even patients who had brain metastasis also were included in the trial. And they randomized patients between either osimertinib only, that is only the third generation TKI, or they combined patients with osimertinib with chemotherapy, that is pemetrexed and carboplatin. And after that, the tablet osimertinib was continued, and they stopped the carboplatin after 4 cycles, which is the standard thing to do. And then they kept these patients on regular follow-up. And the endpoint again was PFS, that is how long the cancer was under control in the scans. So because it was a randomized trial, all the other factors were equally balanced in both the treatment arms. And if you look at the endpoint, that is the progression-free survival, by combining osimertinib with chemotherapy, the disease control significantly improved. So with osimertinib monotherapy, the average disease control was only 16.7 months on average, as you can see. And in the osimertinib plus chemotherapy arm, the disease control improved to an average of 25.5 months. So this magnitude of improvement in any trial in stage 4 disease is considered to be significant. And based on the strength of this trial, this combination was approved internationally for usage in these patients. Now, what was more interesting is that this is known as a forest plot, in which we look at the individual factors and see whether any particular patient subgroup they benefited more with this combination. And I would draw your attention to the last parameter here, that is patients who had brain metastasis. So if you see the patients who had brain metastasis to begin with, that is the worst prognostic subgroup of patients, their hazard ratio was 0.47. So that means that they were 53% less likely to have disease progression compared to the control arm, as opposed to patients who did not have brain metastasis, where the hazard ratio was 0.75. So that means that patients who have brain metastasis, they benefit even more when you combine osimertinib with chemotherapy. So again, these curves, they explain the same thing. Patients who had brain metastasis, as you can see, the disease control with osimertinib monotherapy was little inferior. It was only 13.8 months. And with osimertinib plus chemo, it improved to 24.9 months. So, and you can see there's a more significant gap in the curves here on the left hand side. But on the right hand side, that gap is a little bit more modest. There is not a huge difference in the disease control in patients who do not have brain metastasis. So this really impacts our day-to-day practice. In as of today, based on the FLAURA2 data, even if today any patient walks into the clinic who has brain metastasis, who is in a reasonably fit physical status, who can tolerate chemotherapy, on the strength of this data, we advise them that it is better if you take osimertinib in combination with chemotherapy rather than taking only osimertinib alone. Patients who don't have brain metastasis, we are a little bit more equivocal in telling them to take this combination because of the reason I will show you in the next slide, and that is the adverse effects. So even if you look at the overall survival, so what is the meaning of overall survival? So progression-free survival was how long the cancer is under control in the scans. Overall survival is how long the patient actually lives from the time of diagnosis till the time of the patient's death. And this data is still immature. The final data has yet to be published. But there appears to be, as time passes on, there appears to be a gap emerging between these two groups. And it is quite possible that with the long-term data, we will get a positive data for the upfront usage of osimertinib plus chemotherapy, because it obviously makes sense that when the disease control is much superior, obviously the patients will automatically live longer also.